Hello. Hi, good afternoon, everyone. I hope I am audible. Thank you. So we will start in another 2-3 minutes. So good afternoon, everyone. On behalf of NHSRC, I welcome you all for this NQAS implementation webinar series. So today there are two sessions. First session is on patient satisfaction and second is on efficiency indicator. So patient satisfaction is a part of area of concern G, quality management, and efficiency indicator is a part of outcome, that is area of concern H. So before moving forward, we will go through the recap session of the previous session we took on organization framework for quality improvement and productivity indicator under NQAS. After that recap session, we have a patient satisfaction session on patient satisfaction that will be taken by Dr. Naveen. And further, there is a session on efficiency indicator that will be taken by me. So before going forward, let me introduce myself. Myself, Anand, currently working as a consultant in quality and patient safety division. And I'm looking after 4 states, that is Karnataka, Andhra Pradesh, Chandigarh, and Andaman Nicobar. So now we will go through this recap session, and after that recap, my colleague Dr. Naveen will take you through the patient satisfaction session on patient satisfaction. I hope I am audible because I can see some message that no voice yet. Please confirm, am I audible? Yeah, thank you. So this recap session will include both organization framework and productivity indicator. So the first slide is regarding the organization structure under NQAS, and in this we have Organization is structured right from national to the facility level. If we talk about that, the national level, we have Center Quality Supervisory Committee, and under that, NHSRC work as a secretariat for CQSC. At the state level, we have State Quality Assurance Committee, and under that State Quality Assurance Committee, we have State Quality Assurance Unit and quality assessors, which are trained by state and at national level. At district level, we have District Quality Assurance Committee that is headed by District Collector, and District Quality Assurance Unit where District Quality Consultant are manned and hospital managers are manned. At facility level, we have a quality team and quality circle. So these are the member of committees at the different level of hierarchy. So at CQSC, CQSC is headed by ASMD, and joint secretary and additional commissioner of other department are in that committee. ED/NHSRC, advisor QPS, and technical expert elected by CQSC are part of CQSC committee. SQAC headed by the health secretary, MD, NHM, and all the directors of state nodal officer of different programs and state nodal officers are part of SQAC. SQAU consists of State Quality Nodal Officer, State Quality Nodal Officer for Urban Health, Quality Assurance Consultant, State Public Health Consultant, all are part of State Quality Assurance Unit. At DQAC, that is headed by the District Collector. And all the CMOs, CDMOs are part of the District Quality Assurance Committee. And same in the District Quality Assurance Unit, District Quality Consultant, RCHO, ACMO, clinician, District Quality Monitoring Consultant, all are part of the District Quality Assurance Unit. At quality team, this basically at the facility level, we have designated quality team. So these quality team can be of a particular hospital also, and in particular department, we call them quality circle. So in quality team, this if that is secondary care, then medical superintendent is the head of quality team, and if it is primary, then medical officer. So all cadre of staff are part of the quality team, so that we can address quality at all aspect in a healthcare facility. So these are the members of the different quality teams that are present as per the committees. And apart from these committee, we have facility level different type of committees are there. So at DH level, we talk about the Clinical Governance Board, Infection Control Committee, Medical Audit Committee, Death Audit Committee, Prescription Audit Committee, Risk Management Committee, Disaster Management Committee, Quality Team, and Ethical Committee. So these are the part of at the district hospital level. And same are at CSC. At CSC, we don't have clinical governance as of now. So at CSC, we have other committees. At PSC, we have only Infection Control Committee, Prescription Audit Committee, and quality teams. And same for the UPSC and subcenter. So what are the activities that need to be undertaken by quality team? So we have divided this into 8 major activities. Number 1 is NQAS baseline or internal assessment of healthcare facilities. At facility level, this is and second is gap analysis and time-bound action plan. Third is collection of client and patient satisfaction survey. Fourth is calculation of monthly indicator. Fifth activity that need to be undertaken by quality team is development of work instruction and ensure they are adhered at the healthcare facility. Development and maintenance of IEC, cleanliness and hygiene, infection control practices, staff training and capacity building, and monthly meeting. And all these monthly meetings need to be recorded and reviewed in subsequent meetings. Second session is on the productivity indicator. So if we talk about, this is the part of outcome, area of concern H outcome. So if we talk about indicator, basically we measure the results normally on output, outcome, and KPI basis. So what is output? Output is basically the immediate result of some activities which we are doing. And outcome is the result or impact of healthcare services on patient, population, and system. And KPI is the measurable indicator that we look at while while we assess the performance of our healthcare facilities. So these are the number of indicators, productivity indicator that are applicable at different level of healthcare facilities. At ARM Sub Health Center, we don't have KPI, we have only outcome indicators. So at DH, we have 7 productivity indicators. At CSC, we have 8. At PSC, we have 6. UPSC, we have 5. And at ARM Sub Center, we have 8 indicators. These are the indicators which we are talking about. So in this, you can see bed occupancy rate is one of the productivity indicator. So what is productivity? Basically, we are talking about the numbers in this indicator, that how many patients we have treated, how many lab tests we have done, what is the percentage of NCD cases we have managed. So productivity basically talk about the numbers, wherever we are asking about the number of tests done, number of patient, number of OPD. So these are all part of the productivity indicators. So these are the indicator at different level of health facilities. So indicator vary with the type of facility and services delivered at that particular facility. The indicator vary. So at DH, you can see there are 7 productivity indicator. At CSC, we have 8, and at PSC, we have 6. UPSC, we have 5, and at ARM Sub Center, we have outcome indicator, that is 8. So at outcome in ARM Sub Health Center, we have also try to capture the case specific OPD per month, because there are 12 service package at ARM Sub Health Center. So number of case specific OPD per month is also the part of indicator in this thing. So this is a recap about the previous session, and this link we have given on the last slide of the PPT. Using this link, you can access all the training material which we are doing here from that link, and do your implementation activity at your healthcare facilities. So moving forward, I request Dr. Naveen sir for his session on patient and employee satisfaction. Sir is working as a consultant in quality and patient safety division, and majorly looking after the few major states of the country like UP, Punjab, Himachal, and Maharashtra. So sir, over to you.
Thank you, Anand. Good afternoon and namaskar to all of you, those who are participating in this 19th NQAS implementation webinar, which NHSRC is running for supporting the healthcare facilities, staff, as well as program officers working at the state, district level and block level for implementation of NQAS and achieving the targets which are defined by the Ministry of Health and Family Welfare, that by December 2026 we have to achieve the NQAS certification for all level of healthcare facilities, starting from the district hospital to the Ayushman Arogya Mandir Sub Health Center. Recap has been taken by Mr. Anand regarding the previous 18th webinar sessions regarding the organizational framework and productivity indicators, which are covered under area of concern G and H. Basically, this series we are now mainly focusing on the area of concern G, that is quality management, and area of concern H, that is outcome indicators, because various feedbacks received from the stakeholders that some kind of hand-holding or support is required in these 2 particular area of concern. Earlier, initially, we have started this webinar for the support to the Ayushman Arogya Mandir. Now, this is for the all level of healthcare facility. So now my session is regarding the standard G2, that is covered under the area of concern G, quality management, regarding the patient and employee satisfaction survey. तो इसी श्रृंखला को आगे बढ़ाते हुए जो हमारा आज का सेशन रहेगा वो रोगी और कर्मचारी संतुष्टि सर्वेक्षण कैसे करना है फैसिलिटी लेवल पे, एंड हाउ वी आर एनालाइजिंग दैट patient satisfaction survey and taking the necessary action, that is the action taken report on that particular low performing attributes. तो उसके बारे में हम लोग चर्चा करेंगे. तो लर्निंग ऑब्जेक्टिव रिगार्डिंग दिस सेशन इज व्हाई डू वी कंडक्ट PSS. हम पेशेंट सेटिस्फेक्शन सर्वे क्यों करते हैं? जो भी पेशेंट्स हमारी हेल्थ केयर फैसिलिटी में विजिट कर रहे हैं उनका परसेप्शन क्या है रिगार्डिंग द, उनकी मनोधारणा क्या है रिगार्डिंग द सर्विसेज विच वी आर प्रोवाइडिंग एट द हेल्थ केयर फैसिलिटी. हाउ टू कंडक्ट पेशेंट सेटिस्फेक्शन सर्वे, हम पेशेंट सेटिस्फेक्शन सर्वे किस तरह से कर रहे हैं, यदि हम मैनुअल फॉर्म में कर रहे हैं उसमें फॉर्म फिल करवा के पेशेंट से ले रहे हैं, या फिर हम किसी डिजिटल प्लेटफॉर्म पे पेशेंट से सर्वे कर रहे हैं, और कितना सैंपल साइज हम लोग ले रहे हैं. So these are some of the things which are being covered under this particular session. How to analyze PSS and improve patient satisfaction survey. थर्ड कंपोनेंट जो इसका आएगा कि जो हमने पेशेंट सेटिस्फेक्शन सर्वे किया, जो हमारे सैंपल्स इकट्ठे हुए हमारे पास, हाउ टू एनालाइज दीज पेशेंट सेटिस्फेक्शन सर्वेज एंड improve the patient satisfaction. What should be the, how we will do the root cause analysis and how further we will improve so that our patients should be satisfied from the services which are provided by the healthcare facility. So moving ahead, quality defined by the famous Japanese educator and consultant in the field of quality management, that is Norakai Kano, regarding the quality is meeting and exceeding the customer's requirement. So he explained that the customer satisfaction is regarding the various attributes which he feels or perceive at the visit to the particular facility, or regarding any kind of service or product is differentiating. Like some of the patients are dissatisfied that doctor is not available. Some are dissatisfied that the basic services like drinking water or sitting facility. Some are dissatisfied that the drugs or some kind of testing facility is not available. So as per the Kano model, the patient satisfaction or customer satisfaction is basically different for the essential components and the various differentiating attributes. Based on that, we will analyze the why patient satisfaction, रोगी संतुष्टि क्यों आवश्यक है. Quality is a set of attributes that fulfill the needs and expectations of the patient. गुणवत्ता जो हमें डिफाइन की गई है उन गुणों का समूह है जो रोगी की जरूरतों और अपेक्षाओं को पूरा करते हैं. इसमें हमें जोसेफ जुरान की फिलोसफी भी इंक्लूड की गई है. Regarding the quality should encompass these key components regarding fit of use, free from defects and deficiencies, and meet the client's expectations. फिट फॉर यूज, उपयोग के लिए प्रयुक्त, जहां पे भी आप जा रहे हैं, चाहे आप बिल्डिंग की बात करें या कोई भी आप फार्मेसी की सर्विसेज हैं आपके पास, या आपके पास लेबोरेटरी की सर्विसेज हैं, दैट शुड बी फिट फॉर यूज. जो जो हमारे पेशेंट विजिट कर रहे हैं हमें उसकी उपयोगिताओं के अनुसार होना चाहिए. फ्री फ्रॉम डिफेक्ट एंड डेफिशिएंसी, उसमें त्रुटियां और कमियां कम से कम एरर उसमें होनी चाहिए. यदि हम लेबोरेटरी में कोई टेस्ट करके दे रहे हैं लेकिन उसकी जो रीडिंग्स आ रही हैं या उसके जो रिजल्ट्स आ रहे हैं उसमें एरर्स हैं, तो दैट विल नॉट सर्व द पर्पज. मीट द क्लाइंट एक्सपेक्टेशन, क्लाइंट की अपेक्षाओं के अनुसार पूरा करना, कि जब भी पेशेंट यदि विजिट कर रहा है हेल्थ केयर फैसिलिटी पर, डॉक्टर की अवेलेबिलिटी, साथ में आपकी दवाइयों की उपलब्धता और जो मानक टेस्ट हैं उस हेल्थ केयर फैसिलिटी की, उनकी उपलब्धता पूरी होने पे ही पेशेंट का एक्सपेक्टेशंस और सेटिस्फेक्शन बढ़ता है. व्हाट इज पेशेंट सेटिस्फेक्शन, रोगी की संतुष्टि क्या है, इसके बारे में हम चर्चा करेंगे. पेशेंट सेटिस्फेक्शन सर्वे इज ए टूल which provides valuable feedback of perception of the healthcare facility on the basis of perception. जो कि हमारे रोगी की भावनाएं हैं और फीलिंग्स हैं, उनके अनुभव के आधार पर जो प्रतिक्रियाएं हमें प्राप्त होती हैं उन्हीं को हम फीडबैक के रूप में रिकॉर्ड करते हैं हेल्थ केयर फैसिलिटी पर. तो इसमें कवर्ड अंडर द एनक्वास्ट स्टैंडर्ड फॉर ऑल लेवल ऑफ हेल्थ केयर फैसिलिटी, जो हमारा पेशेंट सेटिस्फेक्शन है जिसका हम सर्वे करते हैं, दैट इज अवेलेबल फॉर द ऑल लेवल ऑफ हेल्थ केयर फैसिलिटी स्टार्टिंग फ्रॉम डीएस टू द आयुष्मान आरोग्य मंदिर सब हेल्थ सेंटर. क्वार्टरली फीडबैक शुड बी टेकन ऑन स्ट्रक्चर्ड फॉर्मेट बाय द क्वालिटी टीम. तो इसमें हमें पहले तो ये डिफाइन करना होगा कि हु विल बी टेकिंग द फीडबैक्स एंड व्हाट शुड बी द फ्रीक्वेंसी ऑफ टेकिंग द फीडबैक्स. लाइक फॉर द लार्ज हेल्थ केयर फैसिलिटी जहाँ पे पेशेंट फुटफॉल ज्यादा है, जैसे डिस्ट्रिक्ट हॉस्पिटल है, तो वहां पर हम मंथली भी फीडबैक ले सकते हैं. जहाँ पे छोटी प्राथमिक इकाइयां हैं जैसे कि अपना आयुष्मान आरोग्य मंदिर है या पीएचसी है, तो वहां पर क्वार्टरली फीडबैक भी लिया जा सकता है. दिस फीडबैक शुड बी collected and analyzed to see which are the lowest performing attributes. जो आप देखेंगे कि इनके जो पेशेंट के फीडबैक के फॉर्मेट्स हैं, that whether it is for OPD और IPD, वो डिफाइंड फॉर्मेट में है, तो उसमें आपके कुछ एट्रीब्यूट्स होंगे जिनमें कि आपकी हेल्थ केयर फैसिलिटी थोड़ा अच्छा परफॉर्म कर रही होगी। कुछ में होगा कि जैसे उसमें आपकी फैसिलिटी जो है सेटिस्फेक्शन लेवल पेशेंट्स का कम होगा, जैसे कि उसमें साफ सफाई के ऊपर बात होगी, उसमें ड्रग्स की अवेलेबिलिटी के बारे में पूछा जाएगा, डॉक्टर और नर्सिंग स्टाफ के बिहेवियर के बारे में बातें होंगी। तो इसमें से कुछ एट्रीब्यूट्स पे आपके फैसिलिटी जो है दैट इज परफॉर्मिंग गुड, और सम एट्रीब्यूट्स फैसिलिटी इज लो सेटिस्फेक्शन इन द पेशेंट्स। तो उसका एनालिसिस हमें करना है और उसके बेसिस पे व्हाट शुड बी द एक्शन प्लान वो हमें प्रिपेयर करना है। तो दिस इज द स्टैंडर्ड G2 which covers the facility established system for the patient and employee satisfaction। इसमें हमारे 3 measurable elements cover होते हैं। First is regarding the patient satisfaction survey are conducted at the periodic interval। जैसा कि हमने बात की कि frequency of this taking patient feedbacks, high case load facilities can take monthly feedbacks जहाँ पे OPD और IPD footfall ज्यादा है। Primary care level facilities can take the quarterly feedbacks। Feedback analysis, the facility analyze the patient feedback and root cause analysis। Whatever the number of feedbacks the facility is receiving, the facility is doing the root cause analysis, why this dissatisfaction is happening in the patients, and taking the necessary corrective and preventive actions। Like यदि आपकी ड्रग्स की अवेलेबिलिटी में आपका स्कोर कम जा रहा है तो उस एट्रीब्यूट्स में आप देखेंगे कि ड्रग्स की जो अवेलेबिलिटी है वो कम है, आपके यहाँ स्टॉक आउट ज्यादा रहता है रिगार्डिंग द ड्रग्स, तो दैट इज द पेशेंट इज डिससेटिस्फाइड। तो हाउ टू इम्प्रूव दैट और टू फाइंड द रूट कॉज फॉर दैट, और फर्दर अवेलेबिलिटी कैन बी इंश्योर्ड टू इंक्रीज द पेशेंट satisfaction। Feedback, the third measurable element is regarding the feedback and action plan। Facility prepare the action plan for the area contributing to low satisfaction of the patients। If your facility is not performing like the cleanliness of the OPD area or cleanliness of the toilets, so what should be the action plan? Whether the particular activities have particular in the attribute the satisfaction is low due to the non availability of some logistic items like cleanliness के लिए आपके पास items नहीं है, या training of the staff, the training of staff is inadequate to perform the cleanliness activities। So preparing the action plan and taking the necessary action for the particular low performing attributes is covered, and feedback action plan should be prepared। So that is covered under the measurable element G2.3। So this is the format which is generally used for the patient satisfaction survey in the OPD area. It has 10 attributes. It can be customized or can be changed as per the local language. If the state is free to use any kind of language for particularly these 10 attributes, they can modify as per their requirements। Here we are checking the availability of sufficient information at the registration counter, waiting time at the registration counter more than 30 minutes, 10 to 30 minutes, 5 to 10 minutes, or immediate। So on the basis of that, the patient will give the poor, fair, good, very good, or excellent, or any kind of comments regarding the particular attributes। Third is regarding the behavior and attitude of the staff, cleanliness of the OPD, bathroom, toilets, attitude and communication of doctor, time spent for the examination, counseling of the patient, availability of lab and radiology tests in the healthcare facility, promptness as the medicine distribution counter, that is your drug dispensing counter, availability of drugs at the hospital dispensary, and your overall satisfaction during the visit to the hospital। So these 10 attributes can be asked in the OPD patient satisfaction survey, and sample can be collected for the number of patients which you have taken the feedbacks। This is the patient satisfaction survey questionnaire for the IPD, the patients which are getting admitted to the healthcare facility like DHCSC or PHC with bed। Here again the 18 number of attributes are given against which the patient can give the feedback regarding the services which are provided in the healthcare facility, and these sample size of these feedbacks can be collected from the patients। PSS for the IPD generally taken at the time of discharge when the patient is leaving the healthcare facility after availing the services. So that time we can take the uh, patient feedback for the IPD patients. Then comes the analysis of PSS, how to proceed with the analysis of patient satisfaction survey. So first and foremost thing is availability of PSS forms. I have shown the formats for the OPD and IPD. So printed forms of these formats should be available at the particular locations like the drug distribution counter or may I help you desk or registration counter. So, and at the time of discharge, the ward nurse can take the patient feedbacks for the IPD patient. So these formats should be available or at the particular strategic locations for the taking the feedback from the patients. Filled PSS forms, then filling of the PSS forms. These patient satisfaction survey forms should be filled by the patients. But however, there are some kind of patients like old age patients, disabled patients, or like parents of the newborn child. So these for these patients, the verbal feedback can be taken and that can be assimilated for the particular analysis of the patient satisfaction in the healthcare facility. Adequate sample size, at least 30 samples should be taken for the survey analysis. For statistically correct sampling, at least 30 samples should be required. You can take more samples. That sample size has been also been described in our operation guidelines, which I will show in the next slide. Analysis of PSS, the further part of this is after taking the adequate sample size, you will go for the analysis of these PSS based on the certain quality tools or methods, like you can take use of the fishbone diagram, or you can take help of the PDCA cycle, that how to analyze these PSS. Overall PSS score, it is one of the mandatory criteria for getting the facility certified, whether it is state certification or national certification, that the facility score should be minimum 70% or more, or it should be more than 3.5 or 3.5 on the Likert scale. So this score is a mandatory criteria for the NQA certification at the state and national level. Identification of low scoring attribute, as we have seen that under OPD there are 10 attributes and under IPD there are 18 attributes. So you have to find out which are the low performing attributes like cleanliness or doctor's behavior or non-availability of drugs or diagnostic, and necessary action plan should be prepared for improving the scores. Action plan prepared for the improvement of these low performing attributes. Prerequisite for पूर्व आवश्यकताएं, अवेलेबिलिटी ऑफ फॉर्म्स, जो हमने देखा कि आपके वहां पे पर्टिकुलरली प्रिंटेड फॉर्म्स होने चाहिए विद पेन और पेंसिल की फैसिलिटी, अवेलेबिलिटी, सजेशन और कंप्लेंट बॉक्स जहां पे पेशेंट फीडबैक्स को कलेक्ट किया जा सके एक जगह पे, एक डिफाइंड ग्रीवांस रिड्रेसल मैकेनिज्म होना चाहिए. आप डिजिटल फॉर्मेट में यदि फीडबैक्स ले रहे हैं तो उसका भी तरीका डिफाइंड होना चाहिए कि हाउ यू आर टेकिंग द फीडबैक्स ऑन द digital platform. Clearly displayed information regarding the patient satisfaction survey, and this sample size should cover all categories or age, gender and caste, religion people in the satisfaction survey. This is the way how to conduct the PSS, that is standardized form and format, calculate the sample size, conduct the survey, analysis of survey and find the lowest scoring attributes. This is the sample size which is also being provided in the operational guideline at page number 117 regarding the sample size. It is calculated as per the OPD or IPD footfall in your healthcare facility. If the healthcare facility has number of OPD 200, then it can say take the sample of 132 patients based on the margin of error of -5% and confidence interval of -95%. So minimum sample of 30 is required to be statistically correct, and this can be referred while the calculating for the sample size for the particular healthcare facility. Bigger the sample and better it is, the bigger will be the size, the statistically correct analysis will be done. So these can be referred on the OG also. This is available in the operational guideline. So who will be conducting? The facility in charge will designate a person to conduct the survey, whether the registration clerk in the OPD or ANM staff nurse in the IPD or CHO will be at the Ayushman Arogya Mandir Sub Health Center will be conducting this survey. First, to conduct the baseline survey to take the stock how the facility is performing. Then it can be conducted monthly on the high OPD footfall facilities like district hospital and quarterly basis for the primary level facilities. Employee satisfaction surveys should be conducted once in a year when the annual appraisal is done for the all the employees in the healthcare facility. There is a provision of taking the employee satisfaction survey once in a year, and that format can be decided at the state specific level or state level, that how you will be conducting the employee satisfaction survey. Translate and print the feedback forms OPD IPD as per the local language that can be customized. Take minimum sample of 30 each for the OPD and IPD. Include women and BPL below poverty line patients, poor patients, and maintain the feedback record in a file. The monthly or quarterly feedback form should be kept in a file, or if you are taking the feedbacks in the digital format, that should be available at the time of when you are conducting any kind of assessment or scheduling for the district or state level assessments. So this is the analysis done for the particular patient satisfaction survey, and you can see that some of the indicators which are performing, like serial number 5, it is 1.8, and at the serial number 9 it is again 1.6. These are the low performing attributes. You have to take the average of all the patients which are visiting the healthcare facility and giving the their own score in the particular patient satisfaction survey. So these two low performing attributes should be targeted for further improvement, and action plan should be prepared. So this fishbone diagram will show that which are the contributing factors for the patient satisfaction, like availability of doctor in the OPD, availability of patient care equipment, availability of drugs. Second component is responsiveness regarding the waiting time at the registration counter, waiting time for the consultation, waiting time at the dispensary. Third component is information regarding the directional and departmental signages. Citizen charter is available in the healthcare facility or not. May I help you? Desk is available or not. Empathy, that is behavior and courteousness of the facility staff, whether the doctor, nurse, paramedical staff which is working in the healthcare facility, and promptness of ward boys or gender sensitive services are being provided. Another contributing factor is regarding the out of pocket expenditure, whether the patient is doing expenditure for the meals, informal fees, transportation, drugs, or diagnostic. So these are the assurance, that is privacy, regular doctor visit in the ward, perception of the doctor knowledge, attitude, and grievance redressal mechanism, comfort of providing the basic amenities like drinking water, ambience, and temperature control in the waiting area and the wards, patient calling system or queue management system in the OPD or at the drug counter, waiting area facilities like sitting benches, provision of drinking water, fan, AC, upkeep and appearance of the premises. So these are the contributing factors for the particular patient satisfaction. So you have to identify which are the low performing attributes where we are lacking in the improvement of patient satisfaction, and these particular contributing factors should be identified and action should be taken for that. So this is the patient satisfaction improvement cycle, which is generally known as PDCA, Plan, Do, Check, Act. So calculate the sample size for the OPD, IPD as per the caseload, as we have shown that as per the confidence interval, you can take the sample size on the basis of footfall in the healthcare facility, OPD and IPD footfall, and particular sample size can be calculated or decided. Take patient feedback on PSS formats on the continuous basis, monthly basis, or quarterly. analyze the collected data on quarterly basis, identify low performing attributes, discuss the finding in the quality team as in the recap Anand has mentioned regarding the organizational framework. So there is a defined quality team at the healthcare facility and quality circles in the department like labor room or maternity OT. So they can discuss these findings regarding the low performing attributes in the monthly quality meetings and decide the action plan for improving these low performing attributes. Root cause analysis can be done. Various quality tools can be used for the analyzing the RCA, that is root cause analysis. Corrective and preventive action. Corrective action, how to correct that particular low performing attributes, and preventive action, like if the non-availability of cleaning material, so you can ensure the availability of that cleaning material in the healthcare facility, that is corrective action. And preventive, you will train the particular housekeeping staff regarding cleaning method so that the next time such activity will not happen. So these corrective and preventive action should be particularly taken after the feedback analysis. Plan PSS for the next quarter, and accordingly you can plan for the PSS or patient satisfaction in the next quarter, so that the to analyze these particular all the attributes, whether they are performing or at the level of demarcation, or the score is coming down. Importance of patient satisfaction survey. Patient satisfaction survey is essential tool to assess the continuous quality of healthcare services from the patient perspective, and it is the feedback received from the patient enable the facility to plan the corrective actions for the further improvement. So this is the important component of the NQAS framework, where the patient satisfaction is counted under the certification criteria, where score of 70 or more and 3.5 or more on the 5-pointer Likert scale is mandatory component for NQAS certification. So that is why it is also being incorporated in the quality framework or NQAS certification. So thank you for this particularly session on G2, that is the patient and employee feedback. Now we are proceeding for the second session, that is regarding the efficiency indicators under the area of concern H, and that session will be taken up by Mr. Anand. Over to you, Anand.
Thank you, Dr. Naveen sir, for your session on patient satisfaction. Now we will move to the next session, that is efficiency indicator under NQAS. So before moving forward, as we talk about patient satisfaction or patient feedback, we have feedback system for this training session also. So after a few minutes, Shreya is with us. Shreya is junior consultant in quality and patient safety division. She will post the feedback form in the chat box. So I request all of you to provide your feedback so that we can improve our session in the next series. So I request all of you to attempt that feedback and provide your feedback. Apart from that feedback, we have also prepared one questionnaire for you so that you can assess your knowledge in the end of the session. So a link for the quiz will also be shared in the chat box. So I request all of you to attempt that quiz also. So now we will be moving forward for efficiency indicator under NQAS. So this is a part of area of concern H, that is outcome. And it is the most important part because from this area of concern, we come to know that how our hospital is performing. So previously we talk about the productivity indicator. Now today we are talking about the efficiency indicator. And in further session, we will talk about the other indicators also, that is a part of NQAS. So before moving forward, as I discussed in the recap session also, the output, outcome and KPI, what is the difference? So output is basically the immediate result of a particular activity which we are performing. Second is outcome, that it is an impact of the activity which we are doing. The impact in terms of healthcare services, we are talking about the patient population or healthcare system. And KPIs are the metrics through which we can assess the specific process or program and analyze our performance, at how we are performing. So I will provide you an example of outcome, output, and KPI with this NQAS improvement in healthcare facilities. So whenever we are initiating the quality improvement in our healthcare facilities, the first thing we do is the training of the staff. So whenever we are doing the training of the staff, consider training of the staff as an activity. And if we talk about the output of that activity, we will get the number of staff trained on quality. So in this example, we have considering it as a 50, that we have initiated the training and we got 50 staff that are trained for the quality. So this is the immediate result of that particular activity which we have performed. Second is outcome. So once we have trained staff, now we saw that after training the staff, we have got improvement in our NQAS score. So from 70 initially, we got 88 now. So this is because we have trained our staff and it has some impact on our processes and system. And if we talk about the KPI, that what compliance score we got in NQAS. So we got 70%, we got 88%. So through this, we can measure the improvement in our healthcare facility. So एक एग्जाम्पल की तरीके से मैं समझाऊं आपको, तो आउटपुट आउटकम एंड केपीआई में, तो अगर हम एनक्वास इम्प्रूवमेंट एक्टिविटी इन फैसिलिटी को एक एक्टिविटी की तरह लेते हैं, तो इसके अंदर जो हमारा आउटपुट होगा वो होगा कि हमारे कितने स्टाफ ट्रेंड हुए, आउटकम होगा कि कितना स्कोर हमने इम्प्रूव किया एनक्वास में पहले से अब तक, और केपीआई जो होंगे हमारे वो होगा हमारा एनक्वास का स्कोर कि हम अभी कहाँ पे हैं, अभी हम 88 पे हैं। अब आगे अगर हमें इसको मेजर करना होगा तो हम 88 से शुरू करेंगे एंड आगे देखेंगे कि वो इम्प्रूव होता है या डिक्रीज होता है। तो ये एक छोटा सा एग्जांपल है आपको समझाने के लिए कि आउटपुट आउटकम एंड केपीआई में क्या डिफरेंस होता है। नेक्स्ट इज aspect of measuring quality of care. So under NQAS, we are measuring the quality on 4 aspects, that is productivity, efficiency, clinical care and safety, and service quality. Productivity, as I told you earlier, that we are talking about the volume or numbers in this aspect. So OPD per month, number of delivery conducted, number of lab tests done, all part of the productivity indicators. Then we talk about the efficiency. This is the volume of the services providing in the given resources. We can also say that efficiency is about output to input ratio. We will discuss this in detail in this session. Third is clinical care and safety, that how effective and safe are our hospital services to our patient or to the environment. And fourth is service quality. We talk about the patient satisfaction. That is a part of the service quality or LAMA rate, leave against medical advice. These are the indicators which we cover in the service quality. So under NQAS, we majorly talk about these 4 aspects when we are measuring the outcome of a healthcare facility. Coming to our topic of efficiency indicator. So what is efficiency? Efficiency is basically output to input ratio. Let's suppose we have, for example, if I say in daily life, we have one vehicle. So in that vehicle also we normally observe the efficiency of that vehicle, that how much kilometer it travel in 1 liter of petrol or gas. So that is the efficiency of that particular vehicle. So in the same line, in healthcare facility also, we measure the efficiency of our staff, efficiency of our machines. So all these processes we are measuring in the hospital also. So in hospital, we also look after the efficiency indicator. And so efficiency like dakshata is regarding the output to input ratio. और ये ऐसे मापदंड होते हैं जो यह मापते हैं कि संसाधनों का उपयोग, परिणाम, प्राप्त करने, आउटपुट उत्पन्न करने में कितनी कुशलता से किया गया है, कि हाउ इफेक्टिवली यू आर यूटिलाइजिंग योर सर्विसेज इन गेटिंग द आउटपुट और आउटकम. व्हाई एफिशिएंसी इज इंपॉर्टेंट? सबसे पहले बेटर यूज ऑफ रिसोर्सेज, संसाधनों का बेहतर उपयोग कर सकें, इसलिए हमें एफिशिएंसी मेजर करना जरूरी है कि हम उसको सही तरीके से उपयोग कर भी रहे हैं या नहीं कर रहे हैं. कॉस्ट रिडक्शन, कॉस्ट सेविंग, लागत में कमी, खर्च की बचत से. टाइम सेविंग एंड फास्टर सर्विस डिलीवरी, समय की बचत और तेज सेवा प्रदान करने के लिए हम एफिशिएंसी इंपॉर्टेंट है. इम्प्रूव प्रोडक्टिविटी, दैट कार्य प्रदर्शन में सुधार. अगर हम एफिशिएंसी देखेंगे, एफिशिएंसी मेजर करते हैं स्टाफ की, तो हमें पता लगता है कि कौन सा स्टाफ बेटर परफॉर्म कर रहा है, कौन सा नहीं कर रहा है. बेटर डिसीजन मेकिंग, बेहतर निर्णय लेना. मान लीजिए हमारा कोई स्टाफ है जो ओवरवर्कड है, कुछ स्टाफ होता है अंडरवर्कड होते हैं, तो अगर हम एफिशिएंसी मेजर करते हैं तो हमें पता लगता है कि कैसे हमें रेशनलाइजेशन करना है स्टाफ का अपनी हेल्थ केयर फैसिलिटी में, ताकि हम सुविधाओं को तेज गति से प्रदान कर सकें. So if we talk about the numbers, we have 6 efficiency indicator at district hospital level. Pardon, यहाँ पे productivity लिखा हुआ है, consider it as a efficiency indicator. CSC पे 5 efficiency indicator होते हैं, PSC पे 4 और UPSC पे 3. And these are the list of indicators at different level of healthcare facilities. District hospital पे आप देखेंगे तो हमारे 6 इंडिकेटर्स हैं एफिशिएंसी जो मेजर करते हैं. नंबर 1 इज परसेंटेज ऑफ इमरजेंसी केसेस एडमिटेड एट नाइट, परसेंटेज ऑफ रेफरल आउट ऑफ टोटल रजिस्टर पेशेंट, नंबर ऑफ मेजर सर्जरीज पर सर्जन, ओपीडी पर डॉक्टर, परसेंटेज ऑफ इक्वास विद इन नॉर्मल लिमिट, परसेंटेज ऑफ स्टॉक आउट एज पर ईएमआर. ऐसे ही सीएससी पे आप देखेंगे तो परसेंटेज ऑफ रेफरल आउट ऑफ टोटल रजिस्टर पेशेंट, ओपीडी पर डॉक्टर, percentage of critical emergencies cases, percentage of stock out as per EML, and percentage of emergency call attended per specialist per month. So जितने भी ये indicator हैं, all need to be measured on a monthly basis, and you need to maintain a record for this. There is no need to maintain a separate register for these indicator. You can maintain this as a in a file also. That this is the sheet which talk about the outcome indicator in our healthcare facility for every month. So whenever assessors are going to visit your facility for assessment, so they are in NQAS, we have provision to submit last 3-month outcome indicator or indicator list with the application. So assessor may ask you for the indicator of last year also. So you need to maintain those indicators in a separate file. There is no need to maintain a register particularly for the outcome indicator. Same at PSC, we have percentage of stock out as per EML, percentage of high risk pregnancies referred to FRU, percentage of client accepting limiting on long-term contraception, dropout rate of pentavalent. At UPSC, we have number of outreach session conducted per ANN, dropout rate of pentavalent, number of stock out days for ENN. So these are the efficiency indicator at different level of healthcare facilities. And we will now understand these indicator in detail with an example. So apart from this, we have a formula fitted sheet also that is available on our NHSRC website. You can refer that sheet to get the numerator and denominator of all these indicators, and how you need to calculate those indicators, that is also given in that particular sheet. So here we are discussing percentage of emergency cases admitted at night as an example to make you understand it, how to measure the efficiency and why it is important. So सबसे पहले इस इंडिकेटर का मतलब क्या है कि percentage of emergency cases admitted at night. इसका मतलब है कि the proportion of emergency patient who are admitted to the facility during night hours out of the total emergency admission. तो इसके अंदर हम ये देखना चाहते हैं कि जितने भी हमारे टोटल एडमिशन हुए हैं इमरजेंसी में, उसमें से कितने एडमिशंस हमारे रात के टाइम पे हुए हैं. अब इसको देखना क्यों जरूरी है वो हम आगे वाली स्लाइड्स में देखेंगे. सो व्हाई दिस इंडिकेटर, व्हाट दिस इंडिकेटर मेजर? सो दिस इंडिकेटर मेजर द प्रोपोर्शन ऑफ इमरजेंसी पेशेंट who are admitted to the facility during night hours out of the total emergency admissions. So the formula is numerator will be your night emergency admission and your denominator will be the total emergency admission into 100. और frequency इसकी that is monthly. न्यूमरेटर हमने नाइट इमरजेंसीज को क्यों लिया है, बिकॉज हम परसेंटेज जो है वो इमरजेंसी केसेस का कैलकुलेट कर रहे हैं, और डिनोमिनेटर हमने टोटल इमरजेंसी इसलिए लिया है क्योंकि जो परसेंटेज ऑफ इमरजेंसी केसेस है वो हमारा जो डिनोमिनेटर है अगर हम उसमें टोटल एडमिशंस ले लेंगे तो उससे हमारे जो इंडिकेटर है उसकी परफॉर्मेंस खराब हो जाएगी. सिंस हम यहाँ पे इमरजेंसी केसेस की बात कर रहे हैं इसलिए हमारा न्यूमरेटर और डिनोमिनेटर दोनों इमरजेंसी एडमिशन का ही रहेगा. तो इस बात का जरूर ध्यान रखिए कि whenever you are calculating the outcome indicator, make sure you are using the right numerator or right denominator and right source of data. Major problem is this, that we are facing issue with the data sources. कि people are facilities are using denominator like OPD, total patient registered in healthcare facility everywhere. If they have OPD of 100, so it will be the denominator of all the other indicators. So make sure the indicator, numerator and denominator are related to the percentage of emergency cases admitted in emergency only in this type of indicator. So why we are measuring this indicator? This is the most important question, that we are measuring the indicator, but we don't know why we are measuring those indicators. So in this case, if we say the first significance is that if we are saying that our emergency services are available 24/7, so we will come to know whether it is available 24/7 or not. So the major motive of this indicator is to find out whether your services are available 24/7 or not. Second, reflect nighttime service utilization, that how effectively your services are being utilized in the night time. Help in planning the HR, doctor, nurses, duty staff at night. If you have cases that are maximum getting registered in the night time, so you need to rationalize the staff or posting of the staff accordingly. So this is the significance of measuring this indicator in a healthcare facility. If we talk about the data sources, so since we are talking about the emergency department, so emergency register or emergency admission register will be the data source only. No other source will be used to measure these indicator. If we talk about one example, so here we want to measure the percentage of emergency cases. So our first data item is total emergency admission in 1 month, and our second item is the emergency admission at night in a month is 120. So here we need to calculate the percentage of emergency cases admitted at night. So how we are calculating? Our numerator will be emergency admission at night, that is 120, and your denominator will be 300 because that is the total emergency admission in a month. So by calculating it, we got that 40% of our emergency cases are admitted at night. It means our services are mostly available 24/7 at our healthcare facility. So assessor will look for these indicators. If you are saying that our hospital is 24/7, so assessor will look whether you have any admission in the night also or not. So if you don't have any admission in the night, it means you don't have 24/7 available services. So you need to take care of all these things. Second example is percentage of referral out of total registered patient. So what this indicator measure? The indicator measure the proportion of patient who are referred to higher or other healthcare facilities out of the total number of patient registered in the facility during a specific period. So this indicator will also be calculated on a monthly basis. यह सूचकांक जो है वो कुल जो पंजीकृत मरीजों में से उन मरीजों के प्रतिशत को दर्शाता है जिन्हें किसी अन्य या उच्च स्वास्थ्य सुविधा में रेफर किया गया है. तो इसका जो फॉर्मूला है हमारा, दैट इज परसेंटेज ऑफ रेफरल इज टोटल नंबर ऑफ पेशेंट रेफर्ड आउट डिवाइडेड बाय द टोटल नंबर ऑफ रजिस्टर्ड पेशेंट इनटू 100. यहाँ पे हम रेफर्ड आउट क्यों कह रहे हैं? क्योंकि हमने अपनी फैसिलिटी से उसको किसी और हायर फैसिलिटी पे रेफर किया हुआ है. एक टर्म होता है रेफरल इन, वो भी फैसिलिटी कैलकुलेट करती हैं कि जैसे मान लीजिए आपके जो पीएससी है उस पे आपने किसी पेशेंट को रेफर किया है, तो आपके लिए तो वो पेशेंट रेफर आउट होगा, लेकिन पीएससी के लिए वो रेफर इन होगा। तो वो चीजें आपको उस तरीके से कैलकुलेट करनी है। अब इस इंडिकेटर को कैलकुलेट करने का क्या सिग्निफिकेंस है, कि हम क्यों कैलकुलेट करना चाहते हैं, कि परसेंटेज ऑफ रेफरल आउट, व्हाई वी वांट टू कैलकुलेट। तो द सिग्निफिकेंस इज, if we are referring more number of patient, it means most of the services are not available at our healthcare facility. So it reflects the service availability or service capacity of a particular facility, indicates case management capability. If we are saying ki we are treating a particular disease or particular condition, but we are referring that patient to a higher center, it means that service is not available at our healthcare facilities. Third significance, it also shows the burden on higher referral center. So more in many facility we see that most of the cases are referred to the higher center. It means the higher center is overburdened and they will not treat the patient in a effective manner. So that's why there is a need to calculate the percentage of referral out, and these indicators need to be analyzed on a monthly basis, and jahan gaps hai, you need to tackle those gaps. So data source for this indicator will be the OPD register, referral register, emergency casualty register, or IPD register. Formula I have already told you that numerator will be the number of patient referred out divided by the total number of registered patient into 100. If we talk about the indicators at Arm Sub Health Center, so we don't have KPIs at Arm Sub Health Center, we have only outcome indicators. So we have 6 efficiency indicators at Arm Sub Health Center. Number 1 is percentage of women receiving all full ANCs, dropout rate for pentavalent immunization, dropout rate for NCD, number of stockout days of essential medicine, number of stockout days of essential diagnostic test, and number of yoga session. So these are the efficiency indicators that are available at the Arm Sub Health Center. Their significance is given in this slide, that why we want to calculate the percentage of women receiving all 4 ANCs, because it measures the continuity and adequacy of the antenatal care which we are providing, not just the registration. Strongly association with reduction in maternal and neonatal mortality. Same in case of, if we talk about the dropout rate for NCD, we measure continuity of care, screening, treatment to follow up. Critical because NCD require lifelong management. It is not a one-time manageable disease. So NCD cases need a lifelong management. That's why we are calculating the dropout rate of the NCD. So if the dropout rate of NCD cases in a particular subcenter or a PSC is very high, it means there are some issue. There are some issue maybe with the availability of medicine, maybe with the availability of doctor, technical expertise of a healthcare staff. So all these parameters need to be checked. As discussed by Dr. Naveen sir, ki fishbone diagram is used to find the real cause of a particular problem. So suppose a dropout rate of a subcenter is very low, very high. So you need to map that what are the possible causes of these dropout cases. So you will find out that there are many causes which lead to the dropout of the NCD cases. So you need to work upon those cases. So in subsequent sessions, we have session on quality tools and quality methods also. There we will make you understand that how you need to apply those tools in closing the gap or analyzing the root cause of a particular problem. So this is the link for the KPI sheet which we are talking about. So I will open this sheet and try to give you an overview of how we are calculating all these things. So this is the website which we are talking about, that we have our dedicated website of qps.nhsrcindia.org. You can get all the details regarding the NQAS, Lakshya, Muskan, Kayakalp, and other publication or guideline on this link only. And here you can see the outcome indicator for different level of healthcare facilities, KPIs for different level of healthcare facilities. And if I download anyone of the link, here. So if you can see, we have given the list of KPI type wise, that is productivity indicator, efficiency, clinical care and safety, service quality. And also we have given the numerator, denominator, formula, frequency, source of data, and what is the significance of that particular indicator. So you need to refer this sheet before calculating the outcome indicator in your healthcare facilities, and you will come to know that how to calculate this indicator. And still you have some doubt, so you can reach out to us uh, through your dedicated state consultant, or any of us can respond to these questions regarding the outcome indicators. And if we talk about the KPIs, so in this, what we have done, we have formula fitted this sheet also. So this is the same sheet which I referred earlier, and these are the values which where you need to put the value. Suppose I am putting that total patient bed days is 100 in the month of January, and it is 150 in the month of Feb. You have functional bed, that is 50. So it will automatically calculate your KPI. If you can see, that is 6% or 11%. And we have graphical indication also. So you can refer this sheet at your healthcare facilities, and it will provide you an overview of your performance, that how you are performing during the whole year or during a particular month. So while using this sheet, if you face any issue with the formula or anything, so just reach out to us so that we can correct it. We try to make it errorless, but there may be some chances of error. So you can just reach out to us. We will share the KPI link in the PPT also, and the chat box also. So this is all about the efficiency indicator which we are talking about. And now you can post your queries in the chat box if you have some. And I request everyone to attend the post session questionnaire and provide your feedback on the training. Thank you.
Kindly provide your feedback. Link has been shared, and post session quiz also.
So number one is please give some more example on fishbone and PDCA. Sir, in further session, we will be having dedicated session for the quality tools and quality method. So I request you to attend those session. Or apart from this, we have videos which are available on our YouTube channel. You can refer those also for your reference. KPI का लिंक डाल देगा.
Link regarding this KPI and outcome indicators is also being provided in the chat box. You can refer from there.
So for calculating the referral out, you need to include all the referral you have made in a month, be it from the casualty, be it from the IPD. So all need to be calculated in the numerator. Formula for all calculating all the indicators are available on our link. So you can refer that sheet for the formula. Stock out days of medicine you need to calculate. There are two methods. You need to calculate a average stock out or medicine wise stock out. So suppose paracetamol is not available on 5 days or 10 days of a particular month, then stock out day will be 10 for that particular medicine. So in the same line, you can calculate the average stock out days also by taking the average of all the stock out days of the medicines. YouTube का लिंक है.
One question is regarding number of anemia cases which are treated successfully. So number of patients which are visiting the healthcare facility, and after testing you find that these patients are anemic, and continuously treatment and follow-up is given. So after the completion of treatment, these improvement can be checked whether these patients has been recovered from the particular anemia or hemoglobin level has been raised. Based on that, this successful completion of treatment of anemia can be calculated. Okay. Please download the sheet and it will be open. You can also refer the NHSRC website for particularly this KPI and outcome indicators as Anand has shown.
Requesting everyone to provide your feedback and response on the quiz which we have shared.
Feedback form does not require to mention the patient name. It can be anonymous. Regarding registers and online data, that is digital data management. For particularly primary healthcare facility or Ayushman Arogya Mandir Sub Health Center, we have issued a letter from the Ministry of Health and Family Welfare regarding maintaining of 7 registers which under the quality assurance program, which are being checked in the assessment of Ayushman Arogya Mandir Sub Health Center. And rest of the records can be shown to the assessors in the digital format if you are maintaining the records in some kind of portal. So that will suffice the purpose. Consultation time for particularly like district hospital can be calculated on the basis of time motion study that you have to particularly figure out some of the patients in the OPD and check after the registration how much time they are taking for the reaching at the for the doctor and how much time is taken in the consultation. So that can be done on the monthly basis. Requesting everyone to please submit the feedback and provide the answers in the quiz.
So in the end, I thank all of you for joining this session. The next session will be on 12th March. And we will circulate the agenda of that particular session with all of you. I request all of you to join that particular session. And thank you so much and keep improving your facility. All the best. Thank you.